Hello, everyone. Welcome and thank you for coming to the School of Public Health and Health Sciences Symposium on Suicide Prevention, a conversation in the community, a public health approach to suicide prevention. I'm thrilled to moderate this event with these esteemed researchers and practitioners here today. They'll share their knowledge and expertise in suicide prevention with us. I had the pleasure of meeting Dr. Caine last night and have worked for many years with both Dr. Wexler and Ms. Cunningham, all doing amazing work to help us understand and address this growing problem. My name is Gloria DiFulvio, and I'm a faculty member in the Health Promotion and Policy Department, and your moderator for today. For the past 13 years, it's 13 years, goes by quickly. I've worked with the Department of Public Health and more recently with the Department of Mental Health on their efforts to reduce suicide in the state of Massachusetts. I'm going to just talk a little bit about logistics for today, coffee and some water and stuff in the back. If everyone can just look at their cell phone and make sure that ringer is off, because mine went off in the back a few minutes ago, that would be great. And just outside the doors, there's a gender-neutral bathroom up here, and then on the basement floor is another bathroom if you need to use that, to let you know that. Our event will run until 11:30 today. Our speakers will talk to just about 10:55, just before 11, and we'll have 30 minutes for a conversation back and forth with the panel, and I'll moderate that. But before we actually begin, I'd like to invite Dr. Nancy Cohen, the Interim Dean for the School of Public Health and Health Sciences, to say a few words and officially welcome you to today's event.
Good morning. If you think 13 years goes by fast, 30 years goes by even faster, I don't know what, some law of physics or something like that. But I'd like to welcome you all here today to this new old building too. I don't know, maybe 150 years goes by pretty fast as well. And welcome to the space and the University of Massachusetts at Amherst. This gathering today is a cross-section of our students, our faculty, practitioners in the community, researchers, and it's part of a series in terms of our looking at pressing issues in our communities. And we certainly would have this up there as some of the most pressing issues that we have today. I certainly don't need to tell this group about the statistics of 129 suicide deaths a day in this country, and I understand that in Massachusetts every 14 hours there is a suicide, and it is the second leading cause of death in young folks 15 to 34. Very important problem, and here with us today is a cross section of the interdisciplinary community that is coming together for solutions to this really critical problem. And we have representatives from mental health, health centers, university health services, the district attorney's office, and all sorts of communities around the region. When we talk about suicide prevention, a lot of times the focus is, of course, on the mental health issue and the clinical care that is needed, and of course that's really critical. We rarely do speak about, though, the underlying societal risk factors that might be contributing to this epidemic. And so our keynote speaker, Dr. Caine, who's the director of the Injury Control Research Center for Suicide Prevention at the University of Rochester Medical Center, he's focused for more than 2 decades on public health, community, and health system approaches to preventing suicide and suicide attempts and risk-related adverse outcomes. We have other speakers this morning. Kelley Cunningham, who's the director of suicide prevention, the Suicide Prevention Program at the Massachusetts Department of Public Health, and she will provide a look at ongoing initiatives to reduce suicide here in Massachusetts. Lisa Wexler is an associate professor in our Department of Health Promotion and Policy here at UMass Amherst, and she's an international expert in resiliency and community-based suicide prevention among Alaska Native youth. And then, of course, Gloria DiFulvio, senior lecturer in the Department of Health Promotion and Policy, will be moderating the panel discussion. And Gloria has had extensive involvement in community grant-funded projects in mental health and suicide prevention, including she was a lead evaluator in the Massachusetts Department of Public Health State Youth-Wide Suicide Prevention Project. So, excellent group of experts to lead us in many thoughtful discussions, and I appreciate the opportunity for all of us to come together, and I look forward to learning with you this morning. So thank you all for coming. Thank you.
So we'll see if I did this correctly. Can you hear me properly? Okay, our sound person says that I'm appropriately wired. Oh, I think I'm actually probably always wired, but Lisa will comment to that more than that. So it's really a pleasure to be here, and I've known Lisa for, a long time, yeah. 2005, was it? You were the first? You know, we were doing work on trying to help people develop public health perspectives to suicide prevention in 2005 or so, and we had a series of summer research programs where we brought people to Rochester for a week of immersion. We made sure to do it in the summertime. I'll just say that and not in the midwinter. So I'm going to give you some background about me so you know my biases, points of view, experiences, and you can sort of filter what I say through that. And I think it's always important to sort of present things that way. So as an undergraduate, I worked all through my university education. I was an undergraduate at Cornell in Ithaca, New York. And some think of Cornell as a suicide school. Now, in fact, it doesn't have a higher suicide rate than any other school. We've looked at that many years later when I was involved with putting up the netting that underpins the bridges there. But I worked in the so-called university hospital. They had this hospital. You know, I would never want to go to a hospital. This was like in the middle of town. It was where all the students came when they had flu or other things. And I was a phlebotomist, which is to say that at 6:30 in the morning I went around and took fasting bloods or other things on the weekends when I got these little samples and things and had to test for blood or other stuff. But I also drove the ambulance, and there were two of us. In my first year, 66 to 67, so the 1966 academic year, I'm dating myself here, 7 students died. 4 by jumping into gorges. And I didn't get it. And I can say in some ways to this day, I still don't get it. There's a part of me, I'm sort of a congenital optimist. I'm one of these people that just sort of, you know, sees things even when I'm sad or, you know, have gone through major life stresses. There's a part of me that sort of sees the other side and has a sense of that, you know, I'll be there. And so I started doing what a lot of us do when we don't get it. We start reading. I started talking to people. And throughout the rest of my college career and into medical school, I was very concerned and interested in suicide. Now, I went wayward and I went into neuropsychiatry for a while. I became a psychiatrist, actually. The other thing I did in university is I worked for a fellow named Vincent Dole. And Vincent Dole was the person who developed methadone maintenance. And one of my summer jobs was to go over to Rikers Island regularly and sort of go through all the records and see who we could enroll into a randomized controlled trial of methadone versus treatment as usual, because there'd been a lot of criticism in the 60s that Dole had only enrolled highly motivated people. Now, needless to say, these were people who'd been substance users and addicted for 30 plus years, but they were supposedly highly motivated when the critics came out. So I was supposed to do this summer project all summer long, but in fact I finished the summer project in 3 weeks. So I suddenly became a case manager of taking people out of Rikers, and the first guy I took out was 6'7" and 375 pounds, and I had a really hard time fitting him into the front seat of my Volkswagen. There was me and him, but but we learned a lot together, and over the summer I learned a lot and about life and communities. And while I wasn't, I didn't grow up in any sort of wealth, in the sense my parents worked very hard, and I was always working very hard from the age of 10, it nonetheless was part of the world that I hadn't understood and known, and so this was all part of my immersion experiences. And I also then worked all through medical school with substance users and then through residency and that sort of thing. And this, again, informed a lot of my thinking, because some died not by overdose but by suicide. So a fellow named Yates Conwell and I started doing psychological autopsies. Lisa knows Yates. He's a very, very nice guy. And in 1986, when I was mentoring him, and Yates, by the way, has grown much taller than me, because all the people I mentor become very tall. Yates is now one of the leading authorities in the world on old age suicide. But he didn't really know much about suicide at all. In fact, I said, oh, let's go do psychological autopsies. And his response, I don't know if I ever told you, was, what's that? And this is a fellow who eventually did more than 200 psychological autopsies and works. And I said, well, let's call my friend the medical examiner, because Rochester's sort of a small town. And we spent several years consulting with the ME and then doing research to the medical examiner's office. And in that context, both of us had gone as psychiatrists. And we thought, everything, all we have to do is to get people into treatment and everything will be fine. Now, Yates, particularly interested in the elders, discovered, of course, not surprisingly, that most old men, and in the case of suicide, it's old white men, and they don't like going to see mental health professionals. If you hadn't figured out, old white men are generally not very expressive of emotions. And I'm now in the position to directly make fun of old white men without being, sort of outside the group. And they're not a font of emotion or openness or other things, and indeed we found that they were very, very low on emotionality. And the stoicism that had been very useful during the Depression and World War II was not very useful when life changed. When we looked across the age course, because I was interested in sort of a developmental perspective, and so indeed, one of the things that we decided by the mid-1990s was all our notions about sort of using the mental health system as our catch point and our ability to change the trajectory of people's lives was just totally misinformed. And that we realized that people who'd been in mental health often had dropped out. And even when we looked at primary care, where people had been in primary care, often seeing their primary care docs in the last week of life or the last month, they weren't particularly forthcoming about, hey, yeah, I'm holding up a sign saying I'm about to kill myself. And it was much more important for docs to pay attention to people's lives than what people said at the moment. And that's very hard to do when you've got 6 to 10 minutes. So the point of today is I want to challenge you, and I'm been challenging the field for a while, to really underscore that suicide prevention is not about taking care of suicidal people. There are scant data to suggest that that makes a difference in overall suicide rates. In the same way that I'd say if you wanted to prevent heart disease, you're not going to start when someone has a heart attack. You're going to start a long time before, because the goal is to prevent someone from becoming suicidal. Once someone becomes suicidal, we know that about 60% of suicides occur on the first attempt. And in this country, where firearms account for half of the suicides, they're highly lethal. Now, that's not to say, and I'm going to put another perspective, which is in August 31st of 2017, I stopped my previous job, which was to be chair of a department of psychiatry for 24 years, where we grew our services from 58,000 outpatient visits to about 200,000, and we had 10,000 emergency room visits and another couple thousand mobile crisis visits, and our job was to take care of very suicidal people. And my job as a young attending was I did inpatient work for 9 years, and I really enjoyed that, and I took care of a lot of suicidal people, and 2 died ultimately by suicide. But it's really clear that taking care of someone who already has, quote unquote, the disease, and I'm not saying suicide's a disease, but if you already have heart disease, the probability of you're having, tremendous trouble afterwards is, really quite striking. But remember that most people who attempt suicide don't die by suicide. And that's very, very important. And there are big studies about that. People who were interrupted from jumping off the Golden Gate Bridge, Eventually, I think it was about 6% died by suicide out of about 600. But that's not most of them. So the United States, this is the first, sort of the first half of the 20th century. And it's important to remember, and the reason I show this is because, let's see if I can get my little arrow here. This period before World War I, and this period during the 1920s, even before the Great Depression started, were times of tremendous social disruption and internal migration in the United States. So during the first half of the 20th century, suicide was higher in urban areas than rural areas. During the last half of the 20th century, did I say 19th century? During the first half of the 1900s, it was higher in urban than rural, and then it switched over, it flipped, and now it's higher in rural than urban. Social disruption is a huge factor in suicide. And I just want to underscore that because I'll come back to that as we move through this. Now, if we look at, this is from CDC, from Alex Crosby. Alex and I have had a relationship for years where I bug him and he sends me the most updated slides, and then I redo the slides because he sends them to me on sort of this ugly CDC format, and I try to change them and put them on. But I say that understanding that the ICRCS, which I direct, is funded by CDC. So, I got to be somewhat careful when I say these things. But what you can see now is that suicide since 2000 is increased steadily. It's gone up over 30% in the United States. It's gone up much more in whites, but it's important to remember that blacks and people who are Hispanic, as they're listed in the CDC nomenclature, are about a third, a little more than a third of the rates of whites, but they've actually gone up just as much in the last 10 years or more in terms of the suicide rates. And it's very clear that we're higher now than we've been since the Great Depression. Now, it's also important to remember that the burden, given the demography of the United States, the burden for suicide is in the middle years. So we've spent most money 18 and under, or 19, under 19, and then more recently under 24, based on what's called Garrett Lee Smith funding, and you may know about that. Gordon Smith, who was a senator from Oregon, lost his son, and personally lobbied, ultimately, for the passage of this Congress, and went to everybody in the Senate and most people in the House and President Bush. And they got this funding, which has been very important, but it's really critical to remember that it actually has paid attention to populations that are less contributing to the overall burden. And so as you think about suicide, there are two words you really want to sort of think through as you think about the epidemiology: burden and rate. So there's some groups that have very high rates. Lisa works with groups that have very high rates. Overall, they contribute very small amounts in terms of Alaskan natives to the overall burden of suicide in the United States. That's not to say we shouldn't pay attention to them. Don't hear me say that. But it's really important to disentangle this terminology and realize when you're talking about communities that have especially high rates and the special attention they need, and what do we need to do to change the overall burden or rate for the nation. And those are often different objectives, and they sometimes get conflated. But very clearly, people in the middle years, and it's been the middle years, particularly 35 to 64, that's contributed most heavily to the driving up of suicide rates in the United States, and most heavily to the driving up of drug overdose death rates in the United States. And this is now a very out-of-date slide that Ian Rockett, Ian's from the West Virginia University, just retired recently. The way I describe Ian, he's from Australia who lived in West Virginia for a long time, and it hasn't managed to change his accent. And so Ian and I have become good friends in the last 6 or 7 years and done a number of things on self-injury mortality. We come from very different points of view. He's an epidemiologist and is very interested in misclassification. But the idea being, they're really twofold. One is that suicides related to drug fatalities are very often misclassified as quote-unquote accidents. And the jargon on a medical examiner or coroner's form is, natural causes, suicide, homicide, accident, undetermined. Those are the jargons. Now, CDC turned accident into unintentional, but in the the world on the ground in communities, counties, states, where however the system is set up. It's accidents. And what is an accident? You know, if you think about you're walking down the street and minding your own business in a car that someone's driving too fast, jumps the curb and hits you and kills you, well, that might be an accident. You didn't do anything to change the probability of your death. A piece of, I don't know, an airplane falls out of the sky and falls on your head and kills you. That's an accident. Someone who takes drugs recurrently, as I saw when I was a youth in New York City and working with people out of Rikers, that's not an accident, because they did things recurrently, and however you look at the cause of their behaviors, it was recurrent, somewhat motivated behavior that changed the probability of their death. And so that is what we call self-injury mortality. Something instrumental on the day of death, intention notwithstanding, that led to death. And that's a very important distinction, because it actually has very different, what would you call it, guidance, input, challenge for prevention. In the 1960s, a fellow named William Haddon said, it's not motor vehicle accidents, they're motor vehicle death injuries, and we can change things like airbags in cars, seatbelts in cars, better barriers on the roads, different grading on roads, putting different kinds of speed humps on the roads. I was going through a series of speed humps on Lincoln Avenue this morning. Well, you know, that makes it my behavior. That's actually a universal preventive intervention, because if you're going down the road fast, anybody who goes down the road fast, irrespective of who they are, might break their suspension. So in any case, so self-injury mortality has gone up dramatically, and of course we know it's gone up even more in recent years, as we saw, you know, for instance, originally it was more rural and white people who were dying from drug fatalities. As fentanyl saturated the cities and we saw a change in the epidemiology, we've seen really increase among black and Hispanic deaths as well as white deaths. And this has really been a very, you know, it's like a scythe, and it just cuts. And this is really part of what we have to deal with as well. And what I'm going to come back to over and over again is that the risk factors for death by suicide, by other forms of self-injury mortality, and by natural causes that are related to the same behaviors are basically a common set of risks. And if we think about prevention, we have to look into communities, we have to look into people's lives, understand these risk-related behaviors, and figure out how do we change the risks upstream so the premature mortality that people suffer across our country changes. And that's really part of the message that I'm giving today. Now, I want you to know that suicide prevention is not impossible. So these are data from the Organization of Economic Cooperation and Development, OECD, and you will see this line here is Denmark. In 1980, it had a stupendously high suicide rate. This is Finland. You can see this is around, you know, the late 80s, early 90s. The Finns were doing psychological autopsies at the same time as we were in Rochester, and actually Yates went to Finland, and Marcus Hendrickson, who was part of that group, came to the United States. The difference was theirs went to affect policy, ours went into the research journal. And that's a really, really, really big difference. Now, I'm going to be going to Finland in late May, June. Don't go in the winter. Part of my sabbatical project this year has been to go to England, well, United Kingdom down here, England, which has historically lower rates, although there's some, I think, poor classification there. To Australia, which is now having rising rates. Now, Australia banned firearms pretty much in the mid-1990s after a mass shooting. Their rates went down, but now they're going up, and rope has replaced firearms. So hanging is something that ecologically you can't really restrict in the same way as you can restrict guns. So solving guns is not totally a solution in our country, and despite, you know, arguments about that. When we look at Denmark, they did restrict access to carbon monoxide that was in cooking gas. They just removed it from their cooking gas, domestic gas. They took barbiturates, short-acting barbiturates off the market. They removed some opioids. And about half of they estimate that about half of the suicide decline came from that. But there are other things, like they have much better social support, access to health care, unemployment insurance, retraining, and all sorts of other things, as you'll see, that make a difference in lives such that there is support for people in the face of adversity. Now I'm going to talk sort of quickly about suicidal people. This is not the total focus today, but what I basically want to do is debunk the notion of things like warning signs. Because warning signs do not have predictive validity, and I'm going to come back to that in a very harsh way, because the big drive in the United States is to do more what's called predictive analytics, where you increase what you think is the power of warning signs. And all I'm going to say is I think it's a blind alley, and you'll see why. So I use this, and my colleagues use this. I've published this in the past, and I use whole variations of this. So this is an ecological model. This one is, sort of developed from stuff that WHO came out, but I elaborated much more on it. And I've put together versions of this which talk about interventions, barriers to care, use of e-health. If you wanted to use electronic stuff, you can use this kind of thing. The nice thing about a model like this is it shows you kind of, or implies the interconnected way that we think about things. The lack of utility of a model is it actually doesn't tell you what to do. It says, oh, it's very nice that they're related, but it doesn't actually tell you where to go from here. And so I think it has its illustrative strengths and its limitations. So let's think about people in a developmental way, and at some level I'm a developmentalist. So I'm a psychiatrist, a developmentalist. I actually trained a lot in neuropsychology and ran a neuropsychology program for years, and I'm also public health. So I think of myself as kind of like a multidisciplinary audience, whatever. Or at least I've had 4 careers. So Yates, Conwell, and I started playing around with an idea of how do we kind of illustrate that risk doesn't develop all at once. When we think about risk factors for suicide and we look at a psychological autopsy on the day of death and say someone had all these risk factors, well, these didn't all just snap together in the first day of life. Some, obviously, were from very early times, but others were what happened in relationships. An order of protection at once is a protective factor and a risk factor. For, say, the woman who asked for an order of protection, and they work, maybe 70% of the time. I work with a colleague, Kate Cerulli, who's a lawyer and a Ph.D. in criminal justice and thinks of the courts as a public health system. And, we've looked at this, and 6 months after getting an order of protection, the petitioner, a woman in this, she was looking at women, 6 months later have a marked decrease in depression and suicidal thinking. But we also know that this actually becomes a social isolator for the men on whom it's served, because they may have a very adverse set of relationships, and their only social relationship or social support happens to be actually this really screwed up relationship that they have in their family. So for people with serious mental illnesses, it's a different line than people who have men in the middle years who may have had substance use and family turmoil and other things. Kids with serious mental illness who grow up may have therapeutic noncompliance. I put that in quotes because there's always a power term when you talk about noncompliance with meds. Legal difficulties, functional difficulties. The alternate mental health system, otherwise known as the jails, where they estimate that there are 300,000 people in jails with serious mental illness. As we had deinstitutionalization, Massachusetts being one of the leaders in what I called the flush method of deinstitutionalization. Imagine the old water closet. Remember the old water closets with the cord and the toilet? Well, the deinstitutionalization in Massachusetts was you pulled the cord and everybody flushed out onto the streets. And that was true in New York City, and that's been true in many parts of the country. And so people then were eventually reinstitutionalized. And, the largest places, largest psychiatric treatment centers in the country are like Cook County Jail, LA County Jail. Rikers, of course, was notorious, and, people are trying to shut that down in some ways. But we know that there are different life stories depending on the age of people who die. They have different developmental trajectories. It's true for women. Many of the women who die by suicide, when you look into the data and you look into their stories, sort of sound like patients that Marsha Linehan might have treated with DBT, but they didn't respond very well, and they grew old, and they older, burnt their bridges in relationships, had lots of substance use, lots of violence, actually, when you do mortality follow-back studies and other things. And so, indeed, the highest suicide rates for women in the United States are in the middle years, 35 to 55, roughly. And then it starts to decline dramatically. In some countries, it goes up in later life for women, but in the United States, it goes down. And, you know, this isn't just related to social and life adversity. I mean, one of the things that this is true, the pattern I just described is for white women. Women who are African American have a very low suicide rate, and while we know that they face financial, social, and, you know, kind of turmoil-filled lives in many cases, they have some of the lowest suicide rates of all populations in the United States. And part of the things that we see is that they're really, you know, religion and social connection are very powerful. And these relate to meaning in many ways, and social support, and connectedness, and togetherness. This actually goes back to I say this as in this developmental framework, you know, the great heat wave in Chicago in the 1990s, it wasn't the poorest people who died, it was the most isolated. And it's very clear that connection is protective, that having meaning in your lives, however you come by that important meaning, is also protective. And elders have a very different pattern where you see role changes and losses, medical illnesses, chronic stressors, and again, into a peri-suicidal state. Now, I want to come back to the men in the middle years, because one of the things that we see is a lot of people die in the first month after being discharged from psychiatric hospitals. And this is well known, and it's true around the world. Now, one of the things that's very striking is that as an inpatient doc, I knew that I could treat the depression, get them off alcohol or drugs or whatever, and at the time of discharge, somebody looked pretty good. You know, they had gotten it together in a lot of ways. But it didn't mean that his wife wanted to give up the order of protection or that his employer wanted to rehire him. And he'd go out and live in an SRO or what other things. And as it were, without dealing with the social factors and the relationship factors, I viewed these folks as ready for relapse. And it's very important to understand the complexity of this. It's not just between the ears. That's one part, but it's also in the context and the surround. Now, that brings me to this, and this is the work of Caine and Deaton, and Caine and Angus Deaton, who've been talking about deaths of despair. Now, they got some pushback because they were talking about the decreased life expectancy of the United States being singularly related to increased mortality among white men and women in the United States, especially in economically deprived areas. And this is very important work. They're working on a book now. And they were talking about the relationship between suicide, chronic pain, social, difficulty socializing, and drug mortality, and marital status, either not married or divorced, not in the labor force. And basically, they're talking about the erosion of social systems and economic systems and really community cohesion in the United States, going back to the 1980s. And one of the things that they point out is that this is really related to people with less than a university education, less than a college education. Now, there was criticism of their work because a lot of people said, well, people, Hispanic folks and black folks have much higher mortality rates than whites, and Caine and Deaton said, you're right, but at the time they did their first work, those are still going down, whereas the white population is turned upward and is going upward. Now, what's happened since the fentanyl invasion is it's turned up for the other groups as well. And so we're seeing really something that's not seen in any economically developed country in the world, which is so far 3 years in a row of decreasing life expectancy in this country. And so this is a really profound public health problem, and it relates to suicide, drug overdose, hepatic disease, other kinds of diseases. And this sort of starting to bring me to where I'm focusing, knowing that there's a little press on time here. So this is CDC data out of Deb Stone and Kristen Holland and others at CDC, people I've worked with. And they looked at men and women who were, they took, half and half. Now, that's not the true representation of men and women in the suicide picture, where there's 3 to 3.5 suicides among men for every one among a woman. But they were looking at these figures, and things like intimate partner violence, job problems, health problems, family problems, separate from intimate partner violence, legal problems. These are all contributing factors in addition to mental health problems. Now, amongst the mental health problems, while a lot of people were identified, both men and women, as having some sort of mental health distress, only a quarter of the men and, 44% of the women had ever gotten any kind of treatment. Now, we could argue that we need to treat more, but I think one of the issues is how do you get people to come to treatment, as well as how much resources do you have in any case. And 37% of the men had prior, some sort of prior enunciated, because these are informant kinds of information, suicidal thinking or behavior, and almost 60% of the women. So clearly a very distressed groups, but socially distressed as well as having mental health distress. Now, I don't know how well you're going to see this, but I'll make some quick points about this. This is a paper by Mark Olson from last August in JAMA Psychiatry. 5,194 people who came through emergency room with a non-fatal opioid overdose, and then looked at their mortality over the following year compared to expected national averages and national data. Now, what they found was, not surprisingly, a stunningly high mortality rate. And this is the far right column, for those of you who can see it or not, and I guess we'll have to make slides available so that people can look at this. It's 24 times higher than what would be expected. Now, not surprisingly, suicide is, when you can see this, suicide is 26 times higher in this population than would have been expected in the general population. Now, because these were people who had shown up with substance use, 85 times higher substance use mortality. So we say, wow, that's just off the charts. But when you add up the numbers, you'll see that what so-called external causes, suicide, accident, substance use causes, account for 33% of the mortality in the ensuing year. 67% is from natural causes. Now, and when you look at these natural causes, infections, circulatory, respiratory, GI, and other things, cancers, these are behavior-related, largely behavior-related deaths. From England, following up over a period of about 3 decades, people who had presented to emergency rooms with a suicide attempt. They called it deliberate self-harm. And this is years of life lost. And sure, accidents and intentional self-harm, lots of years of life lost, the dark bar being men, the lighter bar being women. But circulatory disease, digestive disease, cancers, respiratory, nervous system diseases, infections, endocrine things. So what's clear is whether you present with a drug overdose or you present with a suicide attempt, 80% of the people who presented with suicide attempts died from natural causes. Now, it was related to the behaviors. When you look at these diseases and you know how disease mechanism works, I still remember some of that from medical school, it is related to the behaviors that these people have. Now, this is another way of looking at this. Is a fellow named Neilman who cohort of people, late 1940s England. They were following this group longitudinally, watching them develop. These are people who were defined as having some sort of early life adversities, behavioral risk factors, and other things. And what was clear was natural death, that's the higher one, death due to natural causes, exceeded both accidental deaths and suicides. Another way of looking at this, Neilman did another study with a huge literature review with over 100,000 people. This is kind of hard to explain. I'm going to try to do it quickly. The dark bar is standardized mortality ratio. So just think of it as how many times higher than the general population. The dark bar is suicide. The middle bar is accident, which often is drug or other things. And this bar, crosshatch bar, is natural cause. Now remember, this reflects the denominator, so natural cause causes many more deaths. And what he did was he looked through the literature and said, what are the risk factors for suicide? Got 16 risk factors and then said, I'm going to look at longitudinal studies and see what people died from. Ultimately, I mean, he was interested in what he called the continuum of risk, and that people with suicide would die more often. People with self-harm would die more often from suicide. But for me, the takeaway is across all these risk factors, there's a huge natural mortality. And so if we think about this, and this will get to our prevention, I'm going to run over, unfortunately, I'll try to be quick. So if we have risk factors for drugs and risk factors for psychiatric and risk factors for natural disease, some of those will, natural fatalities, some of those will end up as suicides. We call that, when they all different risks come together, we call that equifinality. It's a term that Dante Cicchetti used, but I actually read about the concept from a fellow named Hendrik Wolff in 1976. It was actually, for me, one of the formative books that I read to think about this. Now, the other point, which is really for our discussion, is all the risk factors for suicide. Sure, some people who have these so-called risk factors in their lives end up with overdose death. And some end up with a suicide death. Most of them end up dying prematurely from natural diseases or natural causes. And this has a lot of implications on how we think. Who do we grab? Who do we try to engage as we try to change the trajectory of people's lives? Now, don't hear me say that we don't deal with people who are suicidal. Of course we do. They need treatment. But that's not the same thing as prevention. So, public health rationale, people intent on suicide often don't seek help. They seem normal. You do psychological autopsies, you hear over and over. He just seemed like he always was. Now, this may be some people who sometimes have, like bipolar disorder, but he was always this way up and down. And I never saw a difference, or schizophrenia. But most often it's people who went to work, did their things, didn't communicate. Fatal attempts are the first. So-called risk factors are not predictive. A common factor cannot predict a rare event. And it's very important to understand this. And I'm going to give you this, what I call trying to find the needle in the stack of needles. So, the suicide rate in the United States is 14 per 100,000. Good literature suggests that if you're discharged from hospital after a suicide attempt, you had a major depressive episode, you make a suicide attempt, you get discharged, the rate is 50 times higher. So that's not anything to sneeze about. That means it's 700 per 100,000. So in the coming year, I have a pool, not the general population pool, but a pool of 100,000 people who've been discharged from hospital after a suicide attempt. I've changed the characteristics of the pool. And 700 will die in the coming year, and 99,300 won't. So if I'm the great big giant who puts the hand and picks up one and looks them in the eye and says, well, you have a 99+% chance you won't die in the coming year, and drop them back in the pool. Right? When you try to pick out a person out of a population and ascribe to that person the characteristics of the population and a probability, that's called an ecological fallacy. Now, it's not to say that the 100,000 people discharged from hospital don't need treatment. They do. Absolutely. But that's different than a suicide prevention program. We have had many efforts over the last 30 years to have warning signs, to have more mental health. The amount of antidepressants have gone skyrocketed. It hasn't changed what's happening. Now, there are ways to prevent suicide. The U.S. Air Force did one. It worked for a while and then went away, and I was sort of the senior author on this. I'm in the et al. Territory. Carrie Knox, one of the people I mentored, and sadly passed away a couple years ago. Carrie was quite short, but she also grew taller than me. The Air Force did a basically full-bore community prevention program with every element that it could find. It was ignorant, admittedly, by themselves about what might work, so they did everything. But they worked a lot on community culture, both formal and informal, cohesiveness, connectedness. And what was important was that not only did they reduce suicide, they reduced homicide and accidental death, and also reduced severe and moderate family violence. Why? Because they set up a huge family violence program, which started getting people, when they were arguing, not violent. They defined family stress. They also set up financial counseling programs. They changed their policy on what could be revealed by psychologists and mental health professionals who have a dual agency problem in the military. And for a time, in a very sustained way, they had an impact. So the argument I'm going to make is that common risk can predict common outcomes. And that basically what we want to do is prevent all-cause mortality in order to prevent death from suicide and risk-related causes. And this isn't to say this isn't going to involve those of us who are mental health professionals, because it's all about behavior. Now, that could be smoking, drinking, substance use, family violence, interpersonal violence, or ACEs, early life, adverse childhood experiences, and how we deal, not just to prevent them, but deal with people who've already been exposed to them, who are adults now. How we deal with social connection, how we deal with relationships, thinking back to the model, the ecological model. So if you think about youth and young adults and you put it in a developmental context, obviously we want to look at disruptive family factors and ACEs, and we want to do a lot of things in communities. Clearly, we would call that universal and selective interventions. I'm not going to get into jargon today. But
So thank you, Dr. Caine. That was lots to discuss there, and we'll get to that very soon. I want to introduce Dr. Lisa Wexler, an associate professor in community health education and my colleague for many, many years. That's gone by very quickly, too. Her participatory research program draws from critical and social theories, intergenerational narratives, and indigenous wisdom to illuminate the problem of youth suicide and explore the promise of resilience to encourage strategic action in indigenous communities. It's all you.
So I'm going to wait until this actually opens up.
So that's the only mic that seems to be working.
Okay.
Or you can grab it.
Everybody can hear me? Oh, good. I get yes. Okay, great. So as this bounces around, I'll do an introduction just so that you know why I live in Massachusetts and work in Alaska. I went up to Alaska in 1995 in Northwest Alaska, worked for a tribal organization as a counselor. And in that role, started to sort of be responsive to suicidal crises all the time. So when we look at the developmental model that Eric laid out, just the tip of that iceberg. And for somebody that grew up in Florida and was sort of transplanted to a very different place with very different meaning systems, very different ways of talking about suicide, I was really ill prepared to be responsive in a good way to suicide, and ended up being put in a position as a very junior clinician to decide how dangerous an individual was, based on really an incomplete picture of how things worked. I too was trained in gatekeeper training, and so I had this false assumption of warning signs causing suicidality. And had a very incomplete picture of the texture and the community that could be helped provide support for those individuals. So in that context, was put in a position to decide whether a person was in danger of suicide or not. And if they were, not only did we pull them out from their local small communities, brought them to the hub community where I assessed them, which was hundreds of miles away from their home, airplane ride out, because there's no roads where I worked. If I decided that they were high risk, they would go down to Anchorage, which is really far, 500 air miles away, where they were assessed again. And if they were seen to be at risk, they were sent down states to the lower 48, to the United States of America, said by many of my colleagues up there, to be assessed again, and many times kept away from their community and cultural strengths for years at a time. So that system doesn't work. Doesn't work well for the kids that are put into it, doesn't work well for the clinicians who are sort of in this trap of actually a colonial system that really does harm to communities. And so really set to work to better understand what we could do in a more supportive way. And so I'm going to share with you, I actually cut a lot of slides, which is good, but hopefully we'll generate some conversations about suicide prevention and how we can think about building community capacity to address suicide. So that's my talk today. All right, and we're up and running, which is terrific. All right, so I'm going to start off with a very sort of epidemiological, very data-centric conversation about suicide, and then I'm going to move into like how we can put that to use in communities on communities' terms, which is a really important thing because, as Eric was saying, we need to consider the ecological systems within a community, but also how meaning systems and how community systems can be put in service of support for young people. And so I'm going to talk a little bit about that. And then I'm just going to talk about one part of the work that we're doing in one part of the state. And so I'm going to make it as small as possible to give you really tangible ideas for how you can put suicide prevention to work in a public health way in communities. So that's going to be my talk today. Okay, so starting off with stats, because that's how we do it in public health. So I work in the Northwest Arctic and in Bering Strait in Norton Sound and in the YK Delta. So all of those dark regions of the state that have the highest suicide rates, that's where I work. Now, different projects. I'm going to really focus today on Northwest Arctic. And I'll give you a little bit of insight there. So in Northwest Alaska, we've been doing a lot of work with the tribal community to sort of understand some epidemiological factors that might contribute to suicide. So as you can see, this is true for a lot of indigenous communities where young people are dying by suicide at a much greater rate. This is true for young people in the United States overall, but in indigenous communities it's particularly emphasized. And older people's suicide, elder suicide, is pretty unheard of in indigenous communities. And we can talk about social roles, we can talk about social disruption and need, and we will, because that's a really important factor here. So in indigenous young people's lives, there's been a lot of changes over the past 100 years all over the US, but if you look at the Arctic, that's really occurred in the last 50 years. And so when we look at the differences that have come about in the last 50 years, when we talk to elders, they were doing subsistence living, getting most of their food from the land, speaking indigenous languages, so in this region, Inupiaq, being the leaders in their communities, being the knowledge bearers in a lot of different ways. Settlements came, and people were forced to move into one spot instead of migrating with food. And they were put into groups in ways that they hadn't been before. So in this region, people were migratory, small family groups, moving with the fish and the caribou. In particular, those are the main food sources. And with the Indian Reorganization Act, and then later when Alaska became a state, there was a huge push to get people into settlements. And when people were in settlements, there was a great ability to share diseases. And so Spanish influenza wreaked havoc in communities. And their whole social system sort of had to change based on that. There was also boarding schools going on where young people were forced into boarding schools that really didn't stop until the 1960s. So that means that young people were taken forcibly from their communities, from their families, and put into boarding schools in Oklahoma, for instance, really commonplace, where they were taught not to speak their language, not to be proud of who they were. They were taken away from their family's livelihood. And this happened until the 1960s. I just want to stop right there, think about what that means, and what that means for young people today. So a lot of people that are my age experience that, experience being taken away from their families and their communities for years at a time. Many people my age don't speak in Inupiaq, in this case. And in the 1970s, when there started to be high schools in communities, young people were able to stay there, but still young people are not how should I say it? So many young people don't speak the indigenous language, whereas elders do, and then the middle generation is sort of in this middle part. So you have this intergenerational disruption, if you will. The economy has changed, so there's 80% unemployment in the communities that I work. I already talked about education a little bit. There's so many different forms of structural violence. I explained one to you when I talked about when a suicide crisis happens, when someone like me, because most mental health providers are short-term residents who are there for less than 2 years at a time, so really not enough time to learn about how things work locally, are not trained in cultural humility, for instance, so that they're not really circumspect about their own assumptions about how they're interpreting local people's words and actions and systems of care. And so we're really ill-equipped to do a good job. And many times that means that we're taking young people out of communities very much like boarding schools, and this association between clinical intervention in this way and boarding schools is made all the time when we talk about suicide in this region. So it's really important to think about all these systems of oppression that are at work within our mental health systems and to try and figure out how we can sort of take a step back and support locally generated solutions to suicide. Because wellness in this region and in many other indigenous regions is really linked to cultural practices, it's really linked to community strengths, to elders' wisdom, to subsistence activities and being on the land. And we've done a lot of both qualitative work and quantitative work looking at what's happening in young people's narratives around culture. And culture does tend to be protective, whatever that means. Young people are associating cultural activities, experiences on the land with their best moments. And so how do we create more opportunities for that? So I'm going to go back to EPI, and then we'll talk about how we're going to use some of this information for prevention in this community. So when we look at suicidal acts, and we look at young people versus older people, we actually see a seasonal trend. And Liz was involved in this work. Thank you, Liz. And so basically, when we look at young people's suicidal behavior across the year, we see a bump in suicidal activity of young people in the summer. And people might say, why is that? You know, when there's more subsistence activities taking place, what's happening? So this, I think, goes back, and we've talked to young people and we've talked to older people in the region to try and understand this better. We don't know. We only know, like, these numbers. But people's hunches have to do with the fact that a lot of teenagers are sort of linked into the internet, don't go to camp, don't go out with their families. There's a lot more extra empty time in the summer where young people are together without a lot of different kinds of structures that adults might create for them. And so we're seeing this trend. I'll go back to this particular slide in just a second, but I'll tell you a little bit more about what we've studied and what we've learned, and then I'll try and link that back to what we can do. As a researcher, and this is early in my research time in this region, we also did some retrospective studies, which Eric talked about. And we tried to see where suicidal people might come into contact with health systems. And I didn't mention this before, but most of the people that are dying by suicide in this region are young people. Most people are not coming into contact with mental health. Even when they're referred to mental health services, this goes back to gatekeeper training, 9 out of 10 of them refuse that kind of treatment. So it's not meaningful to them because of a myriad of factors, but needless to say, it's not working for many. And most people that die, family and friends notice something, not necessarily linked to suicide, but something is up with their friend or family member. But they don't necessarily know what to do because the options for doing can be so disruptive. As I said, that can mean a young person leaves the community for 2 years at a time, right? But where else might we be able to identify folks who are sort of hurting and provide ways to sort of move them into some sort of support or services or informal systems? And so we found when we looked in a case-controlled experiment, when we looked at suicidal people that had died from suicide compared to case controls, we found that many people were getting injured. This, again, reiterates some of what Eric is saying. Many of them had come into the ER or the village clinic for an accident related to or an injury related to alcohol. 40% of the people that died were seen in the emergency room in the year before they died for an accident related to alcohol, not a suicidal attempt or ideation. So we really need to be widening our net when we're thinking about suicide prevention at a community level. So how can we use what we know from suicide research for prevention? And so these are some of the ways that we were thinking about it. So we know who's at high risk, young men in particular. And part of that is really thinking about like how we can imagine a bright future for them, how we can help them sort of engage in a purposeful role within the community in many different ways that make sense to them. It's also really important to think about summertime as a really important opportunity to do outreach and support, to have opportunities for young people, young men in particular. We also need to be working with communities to be thinking about how to infuse culture in a myriad of ways within community systems. And we know the method in this region, so in the state, guns are 60% of the suicide deaths. In this region, only 40% of the suicide deaths. But even so, means restriction is a really important thing. How can we do that? How can we make it 10 minutes harder to act on your suicidal impulse? Because that can actually save lives, which many people don't think about. They think, oh, somebody's going to come up with a different means. That's actually not true. If you can make it 10 minutes harder, which seems like a very tangible thing, you can actually work for prevention. So you can think about how you can do means restriction or other things that might be helpful in that way. We have more. So, as I told you, 40% of the people that die by suicide in this region have an injury related to alcohol. So are there other opportunities to intervene? Are there substance abuse interventions that we can be working with communities on? Are there peer-related things that we can do related to that? We have a pretty good surveillance system in this region, has been going on since 1989, and so we know about what factors are associated with suicide risk in this region. Can we help family and friends develop more tools for intervention? And we also know that only 13% of people in this region have been diagnosed or have been seen by a mental health specialist. Very, very few. And so mental health is only part of the solution. And this is something that I think Eric's presentation really emphasized. It's a really small percentage of the solution. And yet 90% of the funding in this country goes to gatekeeper training and referral to mental health services. And that's really missing the boat. It's missing most of the people who are in danger of suicide. So we've sort of embarked on a process for, this is the ecological model, again, different format, where we're really trying to engage all these different systems in learning what we know from suicide and really having them decide how best to use that information in their own lives, in their own communities, in ways that make sense for them. And so this is really intentionally not handing down, this is what you should do, for communities that are, one, under-resourced, and two, really tired of people from outside coming in and telling them what to do, for good reason. There's all kinds of structural violence, and we want to avoid doing that kind of thing. So we want to give people more tools, more opportunities for figuring out for themselves how they want to use the research in self-determined ways. And so we want to provide opportunities for law enforcement, for school staff, for social workers, for healthcare providers, for church leaders and counselors to all learn about what they might do for suicide prevention. We want to also engage tribal leaders. We want to engage planners who are writing those grants, like the Garrett Lee Smith grants. We want to engage elders. Got it. We want to engage different organizations and youth workers within the communities. We also want to really tap into the informal, strong forms of support in community, all kinds of communities, but Indigenous communities in particular. We want to tap into elders, grandparents, parents, siblings, friends, all of those social supports who are eager to be helpful in this. And we want to be helpful for young people. in this community. And so providing support and role models and opportunities for the future and economic opportunities, less access to lethal means, services that make sense, all of these things in concert. And so how can we do this? Well, we're doing it by trying to bring people together within communities to develop a community of practice around prevention and really health promotion. So we don't just focus on suicide, we focus on the myriad of ways in which people can be involved in wellness promotion as well as risk reduction. So both of those things. And we've done that through a process where we train local community activists and leaders to host learning circles. And these learning circles bring together what we know from research. I've shared some of that with you. What we know from research with what they know from their lived experience, from their cultural knowledge, from their community knowledge, and their relationships within communities. Because bringing those things together can be an incredibly powerful thing to make it, to help them think creatively about what they can do strategically in an evidence-based way to prevent suicide and promote wellness. And so we bring together, this is an example of one of the learning circles that we do, where we just share this information. This is what suicide looks like in your community. What do you think? We don't tell them what causes it. We don't actually know, right? They might have a much better idea about that and what they should do about it. Right? So we've had people take this information and create culture camps. We've had tribes create culture camps in the summer. We've had parents decide, okay, I'm going to make sure my kid, my teenager, even if he says he wants to stay home, he's coming with me when we go to camp for the summer. So we've had people do small actions like that within their families, and we've had tribes decide to do big actions, like creating a culture of camp. So all of our learning circles start off with what do we know from research? And really, in a 3-hour session, that's less than 10 minutes we spend on giving information. Because we don't have all the answers, of course we don't. But then we spend a lot of time talking about what they know and how that relates to that information. What do we think about that? How would that apply to our community? And what do we want to do with that in the future? How do we want to use that information in my job as a teacher, or my job as a counselor, or my job as a parent, or an elder in this community? How do we want to use what we know from research in my own capacity to make change? And so we did a pilot study in Northwest Alaska. This is this region. And then we're doing another larger trial in R01 in a neighboring region. And in our pilot, we were able to show that, yes, we can train local people to host learning circles in their community, and they feel comfortable enough to go back and do those learning circles within their communities. We've been able to show learning outcomes. So are people learning things in the learning circles? Are they learning what we expect them to learn as far as prevention goes and what they might do to foster prevention? Have they developed more relationships within their communities so that they can rely on those people when a crisis happens, or way before a crisis happens, when they're just wondering what they might do in the summertime for young people, let's say? We've been able to actually show behavioral outcomes. So are they acting on the prevention information in new ways that they weren't doing before? We were able to show that. And this is my most favorite thing. We were able to use social network analysis to show that not only did the people that went to the learning circles make changes in their prevention behavior and their wellness promotion, we were able to show that. Yeah, okay, that makes sense. And those are highly motivated people, right? Those are the people that show up for everything and that are doing a whole host of things. What's more impressive is that those people went home, went into their communities, went into their families, went into their jobs, and talked to other people about what they learned. And those other people did more prevention behavior. Well, I don't know if it was based on those conversations. We can just show that they did it. So this is a ripple effect, and really that's what prevention needs. So yes, we need huge policy changes, we need more resources, we need social justice, yes. And this is one way to begin to make changes at a community level so that there's less trauma, which is happening way too often in communities. So I'm happy to answer questions. Lots of people were a part of both creating the learning circles. Lauren's sitting here. She's been really great and very much involved in the work that we're doing in this new trial. Susan is here too. She's doing work around learning circles with recovery, and Gloria was involved in some of the early conversations of PC care. So thank you very much.
All right, while they're setting that up, thank you, Lisa, for that conversation. It's great to see how it has evolved. I'm really excited about that. So now I'd like to welcome Kelley Cunningham. She has been involved in the suicide prevention field for 11 years. She spent 7 years in charge of the community education and outreach programs at Samaritans, Inc., spending most of her time talking to middle schoolers, high schoolers, and college students on suicide prevention. Since 2014, she's been at the Massachusetts Department of Public Health in the Suicide Prevention Program, which is how we've come to work together, and in 2018 became the director of the program. On a personal note, Kelley is a suicide loss survivor and has family members who have attempted suicide and is a caregiver to a child with depression and anxiety. Thanks for being here, Kelley.
Thank you. I have to start with saying I am extremely humbled to be here with my other presenters, and I feel as if I'm not sure how much more information I can really give you, and I'm going to skip over quite a bit of my slides and so that we can get to the panel part and be able to ask more questions, but really focus a lot more on what are some of the things that we are doing here in Massachusetts. So please bear with me if you see my slides kind of jump ahead a little bit. I did want to start with this slide only because, as you heard in the beginning of the day, is that suicide rates have increased. And here in Massachusetts, during this time period of 1999 to 2016, suicide rates here in Massachusetts increased by 35%. And when you look at the data from Massachusetts, we're actually considered to have one of the lowest rates in the country. We're generally listed around 47th or 48th compared to our counterparts, as well as the District of Columbia. And as you can see up here, you know, with 47,000 deaths in 2016, and for us at 682, that's a lot of suicide deaths, but our rate is very low compared to the rest of the country. It's startling to me because we think, oh my gosh, we're doing all this great work, and then yet we keep seeing our rates going up, and we need to figure out how to do that. This is just some more comparison data. One of the things to point out here is that the means used in suicide in Massachusetts is very different than what you see nationally. Nationally, it is by firearms. Here in Massachusetts, it is suffocation by hanging. And when we look at things such as, we have tougher gun laws here in Massachusetts, when you look at states that have less resources available that we have here in Massachusetts, that's one of the contributing factors as to why some of these numbers are a little different here. However, the areas that we are seeing an increased number of suicides are in the rural areas of the state. So that's where we're currently trying to focus some of the work that we're doing. Just real quickly about the impact of suicide, and I'm going to jump over to this particular slide right here. Because if you look at this for a moment, what do you see? And I just heard two answers. So we heard a rabbit, we heard a duck. Yeah, you look at, so those of you who saw the duck, the bill, now try to picture those as bunny ears. Okay? And then vice versa for those who saw that as a bunny, now look at that as the beak. I put this up here just to give you an example of, you know, some of the things happening within suicide prevention is when I started in this back in 2007, the focus really was on the lost survivor. When I worked at Samaritans, even though I was in community education outreach, doing all gatekeeper training, we spent a lot of time working with lost survivors. Over the past several years, that shift nationally has gone to attempt survivors. And even here in Massachusetts, that paradigm shift has happened. So we're involving more attempt survivors in a lot of the work that we're doing to try to find out what are we missing? What pieces do we need to do in order to bring down those rates of suicide and help avoid these folks that have a higher risk of suicide now because they've attempted before from being in that situation again. And they've provided us with invaluable information to be able to help with some of this process. So what are some of the suicide prevention efforts that we're doing here in Massachusetts? Yes, we're doing a lot of gatekeeper training because that's what we know. And there are so many people out there that don't know what to do in a situation when a person dies by suicide. So we offer a lot of trainings. But we've also done a little shift where most of our trainings now are not necessarily gatekeeper, but they're more about intervention strategies. And it's more about trying to help a mental health professional help somebody who may be sitting in front of them who may be suicidal. So we started offering CAMS training, which is the Collaborative Assessing and Managing Suicide Risk by Dr. David Jobs. We've offered that a couple of times. We do a lot of assessing and managing risk around suicide. And it's really to help the individual, the counselor, because we know that they're not getting this in their master's programs or doctorate programs. And so a lot of them don't know what to do in that situation when a person sitting in front of them may be suicidal. Some of them are even nervous to ask the question, are they suicidal? And that's what they're telling us in these classes. So we're trying to provide them with these resources to do this. Some of you may be aware we offer an annual conference every year. The conference will be held May 1st and 2nd this year, and it's always, well, the past several years has been at the Sheraton in Framingham. We get approximately 500 plus people both days, and it is filled with folks who are clinicians, school personnel, those who work in suicide prevention field, as well as loss survivors and attempt survivors, and all coming together to really learn about each other and learn about some of the more interesting things that have been happening in suicide prevention. We've been very fortunate recently in Massachusetts to be doing some work or getting some funding to do work around opioids in suicide. So we've been incorporating some of that type of work, and as well as problem gambling in suicide. With casinos opening here in Massachusetts, it was recognized early on that this does present an issue when we talk about suicidality. So we've been invited as part of that to help educate folks, again, doing a lot of gatekeeper work, but in a format that is out in the communities. And part of what we're doing is we have a state coalition, the Massachusetts Coalition for Suicide Prevention, and within that, there are 10 regional coalitions. And the regional coalitions are down in the communities. They're kind of based in a lot of the different counties across the state. And they're out there talking to the community members. They're out there providing that work and education to those folks. Why? Because they know the community and they know how to reach them best. So we do a lot of work with our coalition to be able to get right down in the streets talking with folks. We do have contracts with a lot of community providers across the state. And again, these are people that are doing direct service work with folks out in the field, and they work with a lot of different people. We have within the Department of Veteran Services an organization or a team called the SAVE Team. And I don't know if how many of you have heard of the SAVE Team. It stands for Statewide Advocacy for Veterans Empowerment. And this was formed, this is their 10th year anniversary, actually, so 2009, and it's made up of a team of individuals who are veterans or family members of veterans. And they are trained in suicide prevention work, and they are out in the streets in the communities. And if there is a military personnel member or veteran who is in crisis, they are there to help and support that person and bring them through the process of what resources are available to them. Because we know when a person is in crisis, sometimes they don't know how to navigate the system. And in the veteran field, this couldn't be more well said, right? So that's what the SAVE team does. So we're doing a lot of work around that to be able to support some of those type of groups that really need some of this work. As you know, we do have federal grants. And just to talk a little bit, where are my federal grants? Oh, I think I took that slide out, because in interest of time. But our federal grants, there are actually two in Massachusetts specific for suicide prevention work. One is the Garrett Lee Smith that you heard about, and that's been housed at DPH since 2004, and Gloria came on close to that as working as our evaluator. This past last September, we also brought on another grant, which is the National Strategies for Suicide Prevention. Now, the Garrett Lee Smith grant takes care of ages 10 to 24. But we know that's not it for suicide work, right? The NSSP grant, as we call it, works for 25 through 64. And that's being housed in our Department of Mental Health. And we collaborate and work very closely together on doing this work. And one of the focuses on that, which I really like with what we've heard this morning, it really brings about a better understanding and gives me more hope on this type of work, is we're working directly in the communities. And we selected Cape Cod and the islands because, again, this is an area that's had higher suicide rates. And kind of in a rural area, and how do we work within that community? So the people that are part of this grant with DMH are also the hospitals, it's the emergency service providers, it's the community health programs that are down there, it's the veteran services in that area. It's a whole host of different communities. Samaritans of Cape Cod and the Islands is also part of this group. And it's about working together on how do we help this issue that's going on down there as a whole. We also have Duffy. I was just thinking of Duffy, which works with the homeless down on the Cape and the Islands. And we're doing this with a method called zero suicide. And I don't know how many of you have heard of zero suicide. I'll just jump to that slide. Zero suicide is a bold and aspirational goal, and it's really about taking care of an individual from the moment they walk in the door till long after they've left. Because a lot of times, like we said, you've heard this morning of people that have gone to the hospital and have been discharged and have died by suicide pretty much within a month after their death. What we have known is that 83% of those enrolled in HMO who died by suicide had received services within a year prior to their death. And many times, they weren't in there for anything related to suicide prevention. They could have gone in there for a broken arm. So these hospitals and behavioral health care settings are starting to implement zero suicide. And part of the first thing you do on that is you're doing universal screening. You're screening anybody who walks through that door and asking them that all-important question of, are you feeling suicidal today? And it's amazing. We're doing some of this, too, with 2 hospitals as part of our Garrett Lee Smith grant, and that's in the Berkshire area as well as in Gardner at the Haywood Hospital. So they're both implementing zero suicide as well. And in those 2 hospitals, we have heard stories of people that have walked in there, have been given this screening tool, and they were not in there for suicidality or a behavioral health issue. They were in there for a medical reason, and they screened positive. And these are people that we would have missed. So when you find that, then it's kind of delving in more and seeing if this person needs some services. On the spectrum of it, we also know when people leave services that they are at higher risk for suicide. So we're trying to engage in other types of methods. One is called engagement and follow-up, and this is where Samaritans on Cape Cod and the Islands has come into play, is they are working with DMH right now, and pretty soon with Cape Cod Hospital, of a plan that when a person is discharged from either inpatient or from the ED, that they are invited to be part of this engagement and follow-up program. And what will happen is somebody from Samaritans, they will call them and say, hi, I wanted to check in, see how you're doing. And these are all volunteers. And they will go through that process of compassionate, non-judgmental behavior, just talking with them and just making sure that they're okay as they transition from being in the hospital to outpatient service, if that's where they're going. And the idea is for this to be a bridge so that we don't have this lack in service, because so many people, as we know, are missing that service in between. You heard I have a child who suffers from depression and anxiety, and when she was suicidal, I was fortunate because I already had things in place, because I knew what I needed to have in place. But when I talk to other parents in my community whose child is depressed and they've had to hospitalize them for suicidality, they're at a loss. They don't know what to do when their loved one comes out of the hospital. So part of this process is to help with that so that they don't feel alone. So again, it's bringing in that community together so we don't feel as if we don't know what those resources are. One of the reasons why for the healthcare systems is we know that 24% of the members have a coded of a mental health diagnosis 4 weeks prior to their death. So again, it's about recognizing that part of the zero suicide is implementing their electronic health records, and a lot of folks now are implementing like the Columbia screening tool, which is a very common screening tool for suicidality. They're implementing this right into their electronic health records so that if the person screens positive, a red flag will go up, and that can be passed on as they go through different parts of the system. What we're finding as challenges in this field is that there are many different electronic healthcare records and systems in place within a single hospital setting. So it makes it very difficult for them to understand, person has now left the ED and they've gone onto the medical floor or they've gone onto a psychiatric inpatient. They might have different systems in those places. So there's a lot of talk that needs to happen within these systems. So part of, I guess, what I'm trying to get to in the end here is that within suicide prevention for the state of Massachusetts, we've always done a lot of gatekeeper work, and we're moving towards that upstream approach, and I think really more systems approach too, and understanding that we need to work more within the communities in order to make these bigger changes happening, and using some of these models like zero suicide that I just described. And another one that we're implementing is the good behavior game within elementary schools. This is the way we hope that we can increase the knowledge within these different communities to be able to help somebody who's suicidal and hopefully bring down those rates that we're seeing increase here in Massachusetts. So I thank you for allowing me to speak here today.
Okay. All right, so if I could ask Dr. Caine, oh, there you are. I was like, he left. And Dr. Wexler to come up and join Kelley. We'll do a panel discussion, and I'll just find hands and select you. Yep.
What is the name of the town?
What does the name of the town in Alaska mean? I'm just going to repeat that so others can hear.
Oh, you might be talking about Manilik, which is the tribal health organization, maybe. And so Manilik was actually a prophet, an Inupiaq prophet, who sort of talked about the changes that were going to be happening in communities in, I think it was in the early 1900s.
Yeah. Okay. Thank you. Other questions? Yes.
Okay, I'm going to repeat the question and see if I got it right. So the first question I'm maybe a little bit fuzzy about, but like how do we make sure to do no harm? Is that the question? Okay, and then the second question was about alcohol restrictions. Okay, I'm going to answer the second one first. So alcohol restrictions, I have a colleague, Matt Berman, who has done a lot of work. So rural Alaska is predominantly Alaska Native, and the communities are about 90% Alaska Native. And as I said, they're newly formed sort of settlements in a lot of places, at least the ones that I work in the Arctic. And many of those communities have been dry since the tribes were able to sort of make that dictate in 1971 with the Alaska Native Claims Settlement Act. There are no reservations in Alaska. They did this Alaska Native Claims Settlement Act, which sort of changed things, but each tribe can govern their own communities. So many, many tribes did make alcohol illegal, and there's no association between that and reducing suicide rates. And because there's a whole host of issues that come along with that. And so part of that is that you have then created a lot of felons who are able to make money in places with 80% or plus unemployment by bringing alcohol in. And so like a bootlegged fifth of really cheap whiskey can be up to $75 in dry communities that are off the road system. So it's created this weird economic incentive for bootlegging in many communities. And so there hasn't actually been an association between that policy and reduction in suicide rates. So it's tricky. I think that there is a lot to be said for tribal control over what comes in and how tribes are empowered to act upon their values, and one of them might be sobriety and awakening and community responsibility and those kinds of things. And we are actually doing research with a whole other project to try and delineate what that looks like, how tribes are taking self-determination in governance, and how that might actually protect whole communities from suicide and other related premature deaths. So we're looking at that. I don't have any answers for that right now. Second question, how can we do no harm? And that's really, it's taken a really long time to sort of come to this. I've been working in the region for 25 years, in the region that I talked most about today. And in that process, we've gone from, me sort of going around talking to communities about what meanings are associated with suicide, how can we work for prevention, to bringing a lot of funding in for community wellness teams without much direction from outside. I think that the promoting community conversations about research to end suicide, the PC Cares that I talked about, is a nice balance. I don't facilitate those learning circles, local people do. And so they can decide what to edit, what to change, how to introduce topics, who to invite to those conversations. And then everyone there decides how they're going to use the information. So in some ways, it's a balance between let's build on what we know from scientific research, but really acknowledge local knowledge also, and let people decide for themselves how they want to take that knowledge and move forward in their own lives. And I think that people do that anyway, whether programs acknowledge it or not. And so this is just a way of sort of building a program based on that assumption, is that people know a lot about their own communities, know a lot about what they can do within the relationships within their own lives. And so giving them a little bit more information so they can decide how to move forward with that is sort of a balance, I think. And so we've come to that over a 25-year process. Yeah, and I think that it does balance between like top down, bottom up. But it's not the only solution. I mean, we have a lot of other programs going on too. It's definitely one that quickly gets information to people, builds communities of practice to really try and reduce the level of traumas that people are dealing with on a way too often basis, so that they can do all those other things that need to happen. So, yeah.
Thank you. Yes.
One for Dr. Caine. Another associated topic is those that may face they may want suicide, but they went by law enforcement. So, for example, suicide by cop. Suicide by cop. Right. So, for example, data that shows someone ultimately died of suicide, but their ultimate goal may have been for the cops to do it. So, unfortunately, the last few years, the cop data showed, nationwide about 1,000 or so police shooting deaths in our country. Some of those, however, aren't maybe people who wanted ultimate goal of suicide, whether it be a mass shooting, whether it be they just committed a crime, they don't want to go back to jail. A number of factors there that they ultimately die by law enforcement. So, just curious if any good research or data or information that delineates that, because right now it's showing in either category. Usually it's showing at least one of those thousand versus suicide. So yeah, this is a really tricky area, because when you look at some of those cases, it's really hard to figure out sometimes. I mean, there are people who make themselves outrageous and unapproachable and do certain things and get shot. There are others who, of course, have firearms, or you certainly have seen cases where they had a firearm but it was empty, And so they brandished this, and it led to death. So it's very difficult. I think that, you know, and I'm not a big expert on policing, but there's a extremely illustrative video from England. And this is a fellow who's brandishing some sort of weapon. I couldn't tell whether it was a knife or a bar or something of that sort. But instead of having one or two officers, they had probably a dozen or more with large plastic shields. Huge, you know, these big, you know, sort of riot control shields. And what did they do? They slowly but surely came in on this fellow. And there were no tasers, they had no firearms, and closer and closer and closer. Eventually, you know, his arms were pinned at his side. And he was restrained. And now, clearly, this was someone, as later on, I think he had a severe mental disorder and that sort of thing. So I think, let me sort of circle in this way. You know, in order to sort this out, we're going to ultimately have to figure out how we have a collaboration of mental health and policing and other approaches. The video clip was sent to me by a fellow who does a lot of mental health training for the New York State police, you know, the state cops. And he'd done stuff with the Rochester PD before, and we knew each other for many years, but we had done some stuff with the Rochester PD, run their EAP program. And so very clearly, I think there's going to be many situations where we don't know at the time of encounter what someone's motivation is. But unless there's a life-threatening circumstance threatening to the officer, we need to find a way of having powerful control but not necessarily using violent methods. And that, you know, I think the illustration from England was a very substantial one because they brought numbers, they brought tools that, you know, we don't use these big shields that they were using very often in the United States, and we don't use those kinds of numbers. So clearly I've reviewed cases, I've seen people who've set themselves up for that, and end up dying. And so it's certainly a challenging thing. You know, the problem with suicide as a term is it's elastic, right? So we don't think of early Christian martyrs who had voluntary death as suicide. We call them martyrs. You know, they refused to say that the Roman emperor was God, and they allowed themselves to be killed knowingly. But we call people suicide bombers when they're not our friends. We think of suicide as medical examiners talk about suicide as requiring intention to die as well as self-killing. But we commit people against their will when they're suicidal because we say they don't have the mental capacity to form a judgment in order to protect their own lives. So we have a sort of a common knowledge that suicide is someone, in my view, who's deeply distressed and, you know, instrumentally takes his or her own life on the day of death. But when they have someone else do it for them, this becomes very, very complicated. And of course, the other side of this is when someone, say, is late in life and has a chronic progressive disease and terminal illness, and lots of debates in the United States about physician-assisted death. And then we have my colleague and former mentee, Scott Kim, who's at NIH, and Yates, Conwell, and I have written something about where in Europe they're allowing people with psychiatric disorders to ask for physician-assisted death when they don't have terminal disease, but they say they have untreatable suffering. So our field is really a complex one, and it's one of the reasons that I say, look, if you move upstream and you look for distressed people who have turmoil in their lives and have illnesses and behaviors that put them at risk, we don't need the suicide label in order to intervene. Now, I'm getting far afield from your question, and so I'll make a comment about some of the screening that's done in hospitals. You ask a lot of people whether they're suicidal, and even if they're suicidal, they'll say no. Some will say yes. On the other hand, if you say take an elder and say, wow, you know, you really can't get out of the house the way you used to. You know, winter's made you kind of almost like housebound. That must be really difficult for you because you used to be so social and you see your friends, you know, a couple days a week with coffee and stuff, and you're not doing it anymore. How is it for you? Or I'm really concerned about you. You may learn a lot more than if you say, are you suicidal? Because a lot of people aren't suicidal at that moment. Although their life is shrinking and declining, it's being pruned away, and the complexity of life is disappearing. So I think we are challenged now by trying to find a way to connect to people. And I think one of the really neat things about the community approaches that Lisa's talking about is because it's of the language of people's lives, and how do you begin to make interventions which are context-specific. Now, the sort of circling back to the original question, the instances where I've reviewed where someone was a suicide by cop, these were often very distressed people or very angry people who, you know, or for instance, had a court case that didn't go their way or other things. And so, again, how do you find them? How do you intervene with them? It can be very challenging, and we're going to miss some. And you know, that's inevitable.
I have one. Can I just add
Yeah.
one? Really, like 2 sentences. Okay. So what that made me think about, and it's true if you put death by cop and you put suicide bombers and you put, you know, suicidal people, I think that when we think about the social conditions that give rise to those things, so when we think about oppression and we think about marginalization and we think about shrinking futures, because of the systems that we have in place for people, that is something that can be fixed. And so when we think about suicide prevention only in that clinical sense, we miss all of those opportunities. And so suicide prevention really is creating opportunities for futures for all people. And I think society needs to really think about who we're marginalizing, because the people that are dying by cop are generally speaking not people that look like me, that are educated like me, right? And so they're the more marginalized people in all of those categories, even, yeah. So I think it's important to be thinking about the social conditions that give rise to those diseases of despair, or those yeah. So that's what I wanted to say.
Hi. Oh, that's loud. Mike, is it really loud? Sorry. My question is really, I think, for all of you, but just, I think speaking to that point, I work at the Department of Mental Health. That doesn't mean I know much, but I work there. The solution when folks, so all of it seems to be, how do we get folks to admit being suicidal? But when they do that, like, I mean, as far as like the upstream, the work that happens in the community, but when we do that, what we do is we pull them out of their houses, sometimes with the police. We pull them away from their families. We put them in pretty stark spaces, and then we hold them there for kind of an indeterminate amount of time until their insurance won't pay for it, or kind of the pair of last resort moves on, which is a grim way of saying, like, are there alternatives to that method? Because it's one of the things I struggle with, both as a, you know, kind of a civil servant and somebody who's had suicide attempts in my life, is I want folks to feel comfortable acknowledging these things, but also being pretty transparent about the fact that what treatment looks like today is somewhat arbitrary, really dependent on where you live and who you know. For me, my suicide attempts went away when I had a family, when I had kids, when I had kind of internal meaning. But I don't know how a system inserts that into someone's life. So I'm interested in, we're doing these community conversations, but inevitably when we do them, I'm challenged by someone to, like, what could be different, and I don't always know what that might be.
Yeah, I'll make a couple of comments on this. And I actually want to, first, before anything else, come back to the do no harm comment. You know, one of the things that you have to think about when you set up a screening program of any sort is that you have a good referral system, and that you have a referral system that is
Worth referring people to?
yeah, well, thank you. That was about what I was going to say. I was actually trying to remove the piece of something or other that was in my head, because, you know, the idea of screening in a population is predicated on the notion that you can do something about it. and you can do something about it thoughtfully and in a caring way. Now, the second level is, there's a systems level and a clinician level, as well as the family and the community and stuff. And so one of the really key responsibilities is what do the clinical systems look like and who has a voice in defining and designing those. And of course, in our country in particular, health systems seem to be very far removed from the populations they serve. And this is a very, very complex problem in the United States. Somewhat separate from the notion of do we have universal health care or don't we have a universal health care? I won't get too specific, but I had a major discussion with a leader in my health system, the UR Medicine health system, and I said, well, I'm really interested in population health. This was me, and I was finishing up being chair, and I said, that could mean two things, looking at the entire community and the social and, ecological problems and figuring out how do we have an impact on those, which will then really have an impact on who comes to the emergency room. Or it can be population health management of the people who are insured inside your circle and they already got disease. And he said, well, I'm interested in the latter, because, of course, that's where the money was. And it was very clear. Now, what I found ironic is the goal of our health system was to take care of already 50%, but he's 60 or 70% of the whole population in the community. And I was trying to figure out, well, how are they going to run away from all the social factors and social things that make people come to the emergency room? So the mindset is at a health systems level is really critical. And when you have someone who's acutely distressed, what's your relationships and how does this work? Now then you get to the clinicians, and this gets to how well are clinicians trained, not just to ask about whether someone's suicidal, but how to manage it effectively. And I've overseen clinical training programs, but the roles of clinicians are in some ways limited. Now, I used to manage, I'll put that in quotes, that's the sort of jargon, very suicidal people outside the hospital, because I'd say, you could call me any time of day or night. Now, ironically, they didn't call very often. I had a patient who lived outside of Rochester. I had him come to a hotel in Rochester and stay there because he didn't want to come to the inpatient service, but he'd see me like 3-4 times a week. Just to touch base, wasn't very long. I'm still alive, doc, thank you very much, it's good, and this sort of thing. But it was the connection. It was the presence. Now, we don't have health systems at this point, or clinicians who are comfortable often being present in the moment with the clinician. So we also have to look at ourselves as providers and ask, how do we do that? Now, communities can do that, and often do, by having a friend. There's a very powerful ad, actually. It was a public service ad from Idaho that I saw, where a fellow who was in his 70s, probably his wife had died, was devastated by this and acknowledged being very suicidal and just contemplating how he was going to kill himself, lived in a very isolated way. Talked about his neighbor or friend who lived several miles away, who would bring a cup of coffee at 4 o'clock every afternoon, and did this throughout this guy's depression, and said, well, neither of us said very much, and or I think the neighbor looked at him and he said, yeah, I don't talk a lot and he doesn't either, or something of that sort, and he would be there every day. And so presence is one of the things that we really think about. You can call that social connection. But how we view that in terms of community structure, in terms of relationship structure, and I go back to the comment about African American women who are older, and the notion is, in working with a number of them as a clinician, as I was, growing up as a clinician, and one of the things I learned, and again was taught, if you're a clinician, you're ultimately taught most by the people you work with, and they would say, well, but my neighbors come over and see me every day, so I'll be all right. Even when I'm alone, I'll be all right. And so, I think this is really critical, and we worked with a lot of the local churches and stuff to enhance this fabric of community. So you're bringing up a really complex set of problems, and how much do the people in this room feel that health systems are accountable to them? And is there anyone in the room who feels that the UMass health system is accountable to you? I was a big guy in the University of Rochester health system, I didn't think he was accountable to me, except for the department. Now they were accountable to me, but the system wasn't. So I think that's part of where we have to go with this.
I just want to acknowledge it's 11:27, so maybe we can take another question and then, oh, there's a few questions. Can we go a little bit over since we're, okay, we're going to go a little over. Go ahead.
Have you compared the statistical suicidal rate between indigenous community in Alaska versus indigenous community in Canada? And if yes, if there is a substantial difference, is that related to how the federal government interact with the communities, if they marginalize them or not? For example, in Canada, 3, 4, 5 years ago, one river was declared in the status of a human being, for example. So,
Yeah, that's a great question. So the rates in Arctic Canada are really high, along with the rates in Arctic Alaska are really high. The sort of when colonization happened and when boarding schools happened in both places, it's still really recent. Boarding schools didn't stop in Canada until the 1990s. Yeah. So just to give you, and they did do a public apology, which we never have done as a government in this country. And I think that with the Truth and Reconciliation Commission in Canada, that's at least made the public discourse different. So that's one part of an answer. The other thing to just mention, if you look at a community level across Indigenous communities, there's a really different rate, and rate is per 100,000. So it's a kind of a funny thing to do. And generally speaking, when we think about Indigenous communities across North America, actually, we just lump them all, right? So we put Ganawage, which is a really well-resourced community right outside of Montreal, along with Igloolik, which is a place that's like, in northern Quebec. And it, anyway, so we sort of conflate Alaska Native Indigenous communities all as one thing when we're looking at population statistics, when we're talking about different tribes, different cultural practices, different histories, different experiences with churches coming in and sort of having different experiences with priests or pastors, or all of these things actually play out in suicidality of young people now. And so we're actually in another project looking at some of those historical factors, looking at some of those structural factors, and how they influence current rates of suicide, but really only looking at modifiable ones. And so some of that is how we talk about the past and how we talk about structural violence, that's part of that, but also how institutions have worked to really resist it and figure out how to move forward and on their own terms in ways that work for their people. So it's a complicated political, historical, social, economic, like all of these things play in, which sort of gets to the gentleman's question here about like making people admit to being suicidal to get services, and that is way too late. And so if indeed all of our suicide prevention is focused on that, asking the suicide question and then intervening, we have so missed the boat. We missed the boat because many people that die by suicide do not seek that kind of services. And in the communities that I work, those services are really ill-equipped to handle it, and handle it in a respectful way. So 9 out of 10 people who admit to being suicidal, 10 people admit to being suicidal, only 1 of them will seek mental health services in the regions that I work. So that is a really ineffective system if that's where we're putting all of our energy. And so I just want to actually point out a couple other people. Suzanne Rata has been working on all these projects. So during lunch or during the break, you can also ask her. She has all the knowledge. And I also saw Annalise, who's been working on the larger community systems approach to really thinking about community strengths as reducing suicide risk.
I wanted to get to one more question at least before we break.
I just want to make one more comment. It's really important to not lump communities into singularities. So I just came back from Australia, and they have a huge issue with suicide among, young Indigenous people there. But there are 250 plus different languages across Australia, which reflects a 45,000-year history of diffusion across the continent. The culture variation is substantial. And as much as I use, terms like black and Hispanic, when we think about Hispanic, for example, and talk about suicide, we're talking about a whole variety of different cultures, some from Latin America, some much more influenced from Spain, and a whole bunch of things. And so while we do lumping at some moments, we have to also understand that there's a place for splitting.
One more question.
Yeah, that's a great question. So we've been thinking a lot about that, about what's transferable and what's not, and how do you begin to start conversations with people who might be able to use each other as resources to begin to solve the problems that they're understanding together, or they're coming to understand as a collective. And so I think that there's a couple different ways to do that. I mean, we're thinking about that with the recovery community and service providers that are providing recovery services across the state of Alaska. That's what Susan's been focused on here. We've been doing that in health systems. So we've been thinking about complicated sort of comorbidity within health systems and using case models to begin to talk about having nurses and community health workers and parents and, a bunch of different people come in and sort of weigh in on different cases, to have the different providers in all those different realms, including like case managers, including family service workers, people that are working with the child protective systems. So all of those people working together to really think about problems that are complex, that sort of bump up against all of these other factors. And so unless you're so it's a sort of self-defined community, I think. So yeah, I'm sort of lucky in that the communities that I'm working with are very defined. They're defined in a lot of different ways. Culturally, dialectically, historically, yeah. Okay, so that's really easy. But we have also been working within sort of communities of content, and we've been looking at different institutional communities, within healthcare systems and within health and social services that sort of are willing to sort of focus on an issue that's tangible, that's contained enough that people say, yes, I choose in. And so that they can form their own communities of practice. There's no actual boundaries on that. So you need to get people that want to learn and focus on something together and see value in doing that together. Because these are really complex systems. And if mental health folks aren't talking to employment counselors and aren't talking to child welfare workers and aren't talking to police folks, and where I work, there's no actual police. There's village public safety officers. So, if we're not working across those different kinds of both providers and family members, then we're really missing the boat on a lot of these really complicated problems. But I could say that for diabetes, too. That's a really complicated problem when we start thinking about solutions, right? Or heart disease, or, Yeah.
In the interest of time, Kelley wants to say something, and then Dr.
I just wanted to acknowledge that we know that that's an issue here in Massachusetts, and we've been working currently with the Wampanoag tribe, as they have had a rash of suicides in a very short period of time, and the community was just totally in flux and didn't know what to do. And we're considered outsiders, and for many years they did not want people from the outside coming in to help them. They felt as if, we need to handle it ourselves where we are. And recently they just got to the point, they raised their hand and said, help, can you come in and help us? And, we can only do so much because their structure, when I go in there, is amazing. And all we're doing is providing them with little tangible things here and there to help build their knowledge and use that structure to help bring up the culture in the tribe and help the tribe help each other. So we're learning in that process of how we can help in those types of areas. I mean, there's also, we look at the Haitian community, which has had a rise in the number of suicide rates here in Massachusetts, but yet culturally they don't want to talk about suicide. So it's also about trying to break down the barriers across some groups to allow this to come in and help each other. So we are here for them, but there's only so much we can do, you know, to be able to help them in those situations until they raise their hand. But we keep letting them know, here are resources available, but if it's not related to them, then they don't feel connected to it. So we need to try to work together.
So I'll provide a sobering vignette as a close. We've been working, the ICRCS and a whole bunch of national partners, have been working with the state of Colorado since 2015. Colorado is one of the top 10 states in suicide, with about 1,100 suicides a year for a population of, what, 5.5 million or so. So it's about 20 per 100,000. Dwarfs Massachusetts and New York and that sort of thing. So we have some target counties that we picked based on high burden or high rate. So the high rate counties are west of the Rockies, you know, 6 people per square mile, although in Australia they say that's nothing, it's 6 cows per square mile in parts of Australia. So we went to the first county that we were in December 2017 that we were going to be partnering with it's actually a day where we went to 3 counties. But the first county had 163 suicides in 2016. And we went in there, and the Department of Public Health and everybody said, we are doing a great job. We're focusing on youth suicide prevention. And there had been a little cluster, you know, 3 or 4 suicides in one of the schools there. And so as the morning went on, it became clear there was some split amongst the county folks, but all the resources from the County Department of Public Health were going to youth prevention. There was a lawyer who worked with the state attorney general at youth suicide prevention. So being the smart something or other I am, after about 2 hours as the outsider, I say, well, you know, it's really interesting. You're doing all this stuff. There are 163 suicides in 2016, which was last year, December 2017. I remember 14, 15 were under the age of 19. You could make them all go away and barely have an impact on your rate, your overall burden. What do you say about this? And the response by most is, our priority is youth suicide prevention. Now, we didn't have a big argument about that, although there was someone in the room who said, well, I've been telling them for years, and so on. And so we uncovered what was the split in the county. But clearly, as you begin community-partnered efforts, you have to understand that communities don't necessarily think what the researchers think or what the state leaders think. And we've been working with state leaders who all thought everybody was in line, and they were. And it's very clear it's taken a tremendous amount of time to build a collective view of what it means to reduce the overall rate of suicide in a county and the overall burden. This happened to be the county with the highest burden of veteran suicide in the state. So, you know, and some others are saying, well, you know, you've got a lot of veterans suicide. We're focused on youth. Well, you've got the VA, you've got the military bases. And so this is a big time effort to listen, to pay attention, to build relationships. None of this would have happened without, how many years did you say? How many decades did you say? Yeah. And so I think this is just underscores the kind of work that's ahead and the kind of building that the state of Massachusetts is doing.
Great. So we're going to wrap up now. Thank you all so much for your time and for coming out here today, for 2 of you who drove here. And there'll be some time you can ask questions that you didn't get to ask at the end. And thank you all for coming today and for your time to address this really complicated issue.